right, welcome back to another episode of Paw Patrol with your host, Dr. Jeff Dikis. Tonight, I'm joined by Dr. Tyler Gonzalez. Thanks for joining me tonight.
Oh, you're welcome, man. Thank you very much for having me. Really appreciate it.
Yeah, absolutely. So you and I have crossed paths a couple times on some online educational forums, and most people may kind of know who you are. You're fairly prolific in the world of research and publications, but for those who don't know you, you want to give a kind of a quick background of who you are and how you got to be where you are?
Yeah, sure. My name's Tyler Gonzalez. I'm a orthopedic foot and ankle surgeon out here in South Carolina at University of South Carolina, Prisma Health. I did my undergrad at Berkeley. I did med school and business school at UCLA in California, Harvard for my orthopedic training. Then I did foot and ankle fellowship at Cedars-Sinai in LA. And then I've been out here in South Carolina. I made it this way because my wife's family's from out here. So, but we love it. It's fantastic. And, yeah. So, Jeff, you and I have crossed paths a lot on kind of some of foot and ankle stuff, but heavily we're both pretty involved in the MIS world. And that's where we've kind of crossed paths recently. So I really, over the last several years, have got real deep into minimally invasive foot and ankle surgery. It's kind of the majority of my practice now. It's what I do a lot of my research in, just because I do think that's the way foot and ankle surgery is going, and I think it's best for our patients. So I think there's a lot of unanswered questions, and I'm trying to help answer those for our community, just like you are, and many of our other colleagues are. So that's kind of my interest and focus now, and what it's very exciting, right? Because it's kind of literally a whole new world for our specialty.
For sure. I want to go back a little bit because I think it may be interesting for people to hear how you got involved in foot and ankle surgery. What kind of drew you towards foot and ankle surgery when you were in I assume sometime in residency, you do your rotations and then something kind of strikes your fancy. But why don't you kind of talk us through how you got involved in choosing foot and ankle surgery for your fellowship?
Yeah, I mean, it's a really great question. I mean, I always tell my residents, like, my process was more of a process of elimination than anything. Like I say, not focus on what you like, because we all like things, but everyone has like kind of hard nose. So if you focus on the hard nose, it really helps. So, when I was going through residency, I was like, well, I really don't want a lot of inpatients. So at that time, I was like, okay, well, probably not going to do total joints or spine or oncology. I liked working with kids. I actually, truth be told, I wanted to be a pediatric cardiologist before I found orthopedics. And then I was like, wait, okay, I like orthopedics. I'm going to do that instead. Yeah. So I liked working with kids, but you don't do a ton of surgery. And I really loved being in the OR. Yeah. I mean, that's not true. You can do a lot, but it's harder. A kid's a lot of you do a lot of non-op stuff. So I wanted to operate on kids, but I didn't want it to be the only population I operated on. So then I looked at, sports, foot and ankle and hand, and sports, you do a lot of scopes, and I love scopes, but I didn't want to only do scopes. So then eliminated that. And then trauma, I love trauma, but I didn't like not knowing my schedule. Like, I like knowing what I got the next day, what I have to do.
Yeah.
So I eliminated that. And then it really became down to like kind of foot and ankle and hand. And I like that you could operate on a 5-year-old or a 95-year-old. You could do tendon work and ligament work, bony work, joint replacements, reconstructions. You can do sports and arthroscopy and Achilles and Liz Franks and athletes. And you could do you could do total joint replacement. So you could do all those different things in both kind of hand and foot and ankle. And I just got along better with the foot and ankle people. I had some great mentors at Harvard, and they were really just good people, and they really cared. And they I would fish with them. I would, hang out with them, do dinner with them. And they taught me about surgery and research and family. And so I really connected with them on a personal level. And I just was like, I could be a part of this foot and ankle community. Right. And so that's kind of how I think at the end of the day, the decision-making process came down to the people in the specialty. I think people all in all foot and ankle surgery, as you I think we are humble. We operate on feet, kind of have to be. And, but I think it's a lot harder than most of us expected. But,
Yeah.
I think, it's the people. I think we have a good group of people in all our societies. And, that's how I kind of got to that decision.
Yeah, going back even further, because I think it's interesting because obviously our trainings differ. When you're on your 4th year of school, do you get to pick if you're like, I want to do pediatric cardiology, but maybe orthopedics? How much say do you have in choosing these specialties to be able to say, like, oh, I went on gen surge and I'm definitely not doing that? How often are you not able to even do a specialty that you're maybe interested in, or how does
A,
that work?
a lot. So yeah, so in med school, you basically have to make a decision by your third year to apply to the specialty. So if you want to do general surgery or orthopedics or pediatrics or internal medicine or emergency medicine, you have to decide by your third year.
Mhm.
And then you have to do the whole application process and all the letters of rec. And then you have to go on all your interviews in the beginning of your fourth year. And then there's a match, but you don't have to match. So a lot of times people go unmatched.
Mhm.
They, to your point, some of the more competitive specialties, plastic surgery, dermatology, neurosurgery, orthopedic surgery, there's only so many spots in the country and more people that want to do it. So then they will not match into that specialty and then they won't can't go. And then they have to do something else for that year. So for example, we have not last year, one of our research fellows, she did not match into orthopedics, became our research fellow for a year, did research for a year, reapplied, and now she matched. So now she's in her first year of orth. So, but that doesn't always happen. Some people never match. So in multiple different specialties. So it's kind of like you can't, if you want to do something, you just can't do it. You have to apply and you either get it or you don't.
Yeah, that's how they did it when I was in Pittsburgh with the orthopedic residency at UPMC. They had a whole team of research fellows. It felt like kind of getting a half a foot in the door of like, hey, I want to be here. Here I am.
Yeah.
Let me match here. And, some of them stuck around for even a couple years to do research. Sure.
Other people choose to not match, like you said, and do like a research year to try to bump up their application, get their foot in the door, meet some people. Which I'll be honest, I think actually that, at least in orthopedics, that probably works better because you spend a whole year doing research, you go to conferences, you meet with people, you get to know people. And then like you said, at that program, sometimes you can match, or at the same time, you can start networking with other programs you liked. And I think that time allows you to build your resume. To your point, show your dedication. Like, hey, I really want to do this. I know I didn't match, but I spent
Mhm.
a whole year doing this research in ortho. I've done this, and I really want to be here. And I think programs appreciate that dedication, and that at least for us, all of our we've had we're on our fourth research fellow. All of the ones have not matched before.
Mhm.
Everyone came after not matching, and all of them matched afterwards.
Mhm. Sure.
So, so I mean, it is a good. I think it's a process that can work
Yeah.
potentially.
It's a double-edged sword. If you're likable, they're gonna let you match. But if you're unlikable and they spend a whole year with you, they know they definitely don't want you.
Correct. Yeah, but that yet you can't do anything about that. If you're just unlikable, then you're unlikable, and you're probably doomed anyways. You know.
Let's talk about MIS because I don't know, when did you graduate residency or fellowship, or when did you get into practice?
Um. Uh. Let me think. Almost 2018. So yeah.
Okay.
Yeah.
But you were doing obviously residency and fellowship before
Yeah.
that. So you were
Sure.
involved in all that stuff. So where I'm going with this is trying to figure out how much MIS training did you have early on in your career, because it seems to have been this severe ramp up, this exponential growth of MIS that's really happened more recently. And we learned all these procedures open which we can dive into the benefits of learning how to do something open before you try to tackle it MIS. But did you have much MIS training early on?
I mean, I'll be honest, I had basically zero, right? I will
Yeah.
say that Holly Johnson, who's at HSS, she's one of my mentors, good friend of mine, one of the biggest names in the MIS community. She she was one of my mentors in residency, and she had started to dabble with it overseas in my fourth year, and I had done some labs with her on it, right?
Hmm.
And she was starting to really get into it, but a lot of that stuff wasn't approved yet in the States, even right at that time. Like the Shannon Burrs, I don't even think were FDA approved yet.
Okay.
And so she was, obviously one of the first people in the States to really get up and going with it. And so she had opened my eyes to it. But in my training, really no one was doing it and I never saw it. It wasn't until I got into practice when I really just on my own, I didn't fellowship, did zero. None of my fellowship at Cedars. I mean,
Hmm.
Dave Thorson now does some MIS and so does Tim Charlton and Glenn Fecker doesn't do it, but no one did any MIS. I mean, funny enough, I think it's kind of funny. Dave Thorson, who was my fellowship mentor, who didn't do any of it, I like convinced him to start doing some of it because I would
Yeah.
be like harassing him and be like, he's like, you can't teach an old dog new tricks. And I was like, gee, just try. I didn't teach him how to do it. I was just like, just try some of these things. I
Yeah.
think knowing you, you'll like them. And then, of course, he's like, oh, this is awesome. This is so great. So that is kind of funny when the mentee tells the mentor something to do and they listen to him. It's a funny process, but yeah, I really had no training. It was I really started almost all of it. I mean, Holly did introduce me to the idea and started, but that was early on in the process, and then really and obviously she helped train me when I started going, and I learned a lot from her and still do every day. But then it was really just in practice getting going myself.
Yeah, what benefit do you think there is to our generation or our age people who learned a lot of these procedures or all these procedures open and then have been able to adapt that to an MIS approach versus a younger generation who may only be learning some of these things MIS? Do you think that's a problem? Do you foresee any issues with only being trained how to do things MIS? I mean, that's kind of a leading question because of how I worded it, but what are your thoughts on the transition from open and MIS trained people to just MIS trained people?
Um, well, I think it's a very good point. I've actually never thought of it, and the reason I never thought of it is I don't think we have that problem yet. I
Hmm.
actually think we have the opposite problem where we don't have enough people training the generation in MIS, right? So
Sure.
like
Yeah.
we all do it, but it's like I have residents, right? I train them. I have a fellow. I train him. But it's like there's only so many people like you and me and others that have trainees or are teaching or educating.
Hmm.
So many people doing it don't have residents, don't aren't teaching, right? And honestly, I mean, and again, this is kind of like data from you get like only 10% of foot and ankle surgeons are doing MIS. So
Hmm.
there's 90% are not doing it. So the 10%, so there's only 10% of all of us, Jeff, who are doing it. And how many of that 10% are actually training the next generation?
Sure. Yeah.
So I think you make a very, and I'll address your question because I think it's a really salient point.
Hmm.
I'm more worried about how are we going to train all these people to do MIS because I think it's very important. And as you know, to train them correctly.
Yeah.
That's what I think is really hard. Like, how do we train them the right way to do it? Because you and I have had this conversation. There are MIS is like everyone's like, oh, it's not that hard and simple. There's so many little nuances that make these things like we've talked about the Zadic. Like you just don't take a wedge out and then you're good. Like there's like, where's your apex? How big of a wedge do you take? How
Hmm.
big's your apex? Where do you put your screws? Like
Yeah.
what's your post-op protocol? Like all of these things affect your outcome. And we want people to jump on board, but we want people to do these things safely so our patients have a good outcome because I'm sure just like you, I've had people like, oh yeah, MIS bunions, they don't work. And I'm like, okay, like, let me hear you out. Well, my patients don't do well. Let me see your x-rays. And then I look at the x-rays and they're not done in the right way. And I'm like, well,
Yeah.
it's not the surgery. This is the surgeon, right?
Right. Yeah.
And they weren't trained correctly. So I think step one is we have to, and it'll take time. And it's people like you, people like me, people like Brad and our other colleagues and Holly and other people that are working on educating and training. Then those people will educate and train. Then, and that's like anything in surgery, arthroscopic, laparoscopic, they all had this weird transition, right?
Yeah.
I think at the end of the day, I think doing it open, right, you really understand the anatomy, right? And you really have a good sense. So it almost makes the MIS stuff a little easier, I think, because we understand. We've done it open so many times. We know how to navigate the MTP joint, the subtalar joint, the ankle joint, like
Right.
the first metatarsal. We know what it looks like from every angle. If you've never done it, I think that it you will be there. I think at the end of the day, you'll be okay because I think with most, I use like, general surgeons when they used to do all open gallbladders. Now they do all laparoscopic, but if they have to open, they open, right? They still know their anatomy.
Yeah.
They still because you do have to be a master of the anatomy to do MIS, right? So you got to know where things are. You have to see it in 3 dimensions. So if you have to open, I mean, we're still going to be doing open surgery. There's still going to be things in foot and ankle we have to do open. So I don't think it's going to be as big of a problem. I think some people may struggle a little bit, but I think the bigger problem is like, how do we actually teach the next generation this when so many of us aren't doing it? But again, I think that's just a natural evolution of surgery. Like, it's just going to take time. Like, it's going to take time for people to believe in the process. It's going to take time for people to train. And then I don't think it's a fad that's going to die, but I think it's something that we're just going to have to keep working on how do we better educate people. That's what I think.
Yeah, there is a confidence level that comes from trying to tackle something MIS because it's certainly easier to open it up. I mean, I don't think anyone would argue. Like, I don't think it's better, but I think from a purely surgeon selfish standpoint, look, I can move that out of the way. Look, I can see this structure. Look, I can tell that I've gotten all the cartilage off of the surface before I put my screws across it. Like, selfishly, there is some benefit of opening things up. And there can be a little bit of intimidation there for people to go away from that comfort zone. Hey, listen, I've been doing an open lapidus for 31 years. Why am I going to change now? And that's difficult to try to convince some of these people to make that change, I think. What do you think?
I agree. I don't think that's I I don't think that's really who's going to change all that much because like there's probably no reason, right? They've got great outcomes. It takes them 30 minutes to do.
Yeah.
They have it down, right? What and so I think though, I think it comes into like you and I talked. Let's do a good example. Okay, so you do your open Haglunds. You do it. Well, then you're like, okay, well, I don't want to do the Zadig. Like I have, okay, well, how do you feel about doing your open Haglunds on the really obese diabetic smoker? Oh, I hate it. The wounds, I don't want to do it. Okay, well, maybe a less invasive option for that patient who stops smoking, their A1C is controlled, but you're worried about the wound is a good option for that patient. It's an alternative, right?
Mm-hmm.
And then when they do it on that patient, you're like, oh, wow, that worked. That wasn't that hard. Or like that patient's doing really well. And to be honest, that was with the Zadig, for example, I was like, I'm going to dabble in this in those patients where they're high risk of wounds. Then all those patients started doing well. So then I was like, all right, well, let me do it on the athletes who don't want their Achilles touched. Oh,
Mm-hmm.
wow, they're doing well. Then I'm like,
Mm-hmm.
okay, well, now let me do it on all the other people. And then it's like, okay, now I just do it on everybody. So I
Yeah.
think some of the benefits of MIS, we might not convince the 31-year-old to do it everywhere, but we might be able to say, hey, this is an alternative to this approach. In these patients, you may want to try it. And then I think that's how we get that older generation. I think for the younger generation, it's a little bit easier because it's kind of like the in vogue thing now. So I
Yeah.
don't think it's so hard to convince them to do it. I don't think it's harder to convince them to do it. We just got to train them. But even like the story I told about Dave Thorson, my mentor, he was like, he literally said, you can't, old dog don't want to learn new tricks. And I said, okay, but some of these things, like for the lesser toes, you hate lesser toes. Try some of these little osteotomies and see if you like them, because they're really fast, they're really easy, and patients do well. And he's like, okay, fine. Like I hate lesser toes. I hate tendon transfers
Yeah.
and crossover toe. Like I
Oh
don't
yeah.
like that surgery. And he
Nobody
gave him an
does.
alternative
Nobody
option.
likes that.
Nobody likes it. And then he loves it. So then so then he's like, wow, what else can I do with this? Right. And that opens the gateway. It's like the gateway drug, right? So I think I don't need to, and I don't think we as a society need to tell people MIS is better. You have to do this. I think a lot of it is an alternative to very standard procedures. And it's an alternative that I think a lot of us believe have benefits, including faster recovery, lower wound complications, less pain, less narcotic use. And I think myself personally, that's a lot of the stuff I try to prove, like showing, hey, this may not be totally better in terms of outcomes or function, but maybe it's better in terms of wound complications or pain or recovery or narcotic use. And I think as a foot and ankle society, that's what we're doing, and you doing your shows like this and your educational things and what we talk about, that's what we're trying to get out there, is like that these things work, they have benefits to patient. But it's not a panacea. It doesn't work for everything or everyone either, you know?
Yeah, I think that's reasonable. I'm going to get a little philosophical on you.
Do it. Do it.
What is MIS? What does that mean? So, for anyone listening and hasn't caught on yet, we're talking about minimally invasive surgery. But what does MIS mean to you? How much smaller does the incision have to be? Does it have to be less than this amount of centimeters or this amount of? What does it mean to you when you think about MIS?
Got one phrase for you, baby. Soft tissue is the issue, right? That's so it's really, for me, honestly, it's not about the size of the incision. Size, it's like the size matter, right? So size does matter maybe. So
Damn it.
it's more about the soft tissue, right? So I think that what minimally invasive surgery is we're very conscious of the soft tissue, the tendons, the ligaments, the periosteum.
Yeah.
And you can make, and I have a case that I just did on Monday that I actually sent you to show, because I think it's an excellent example of where I did this whole double arthrodesis all percutaneously, got all my screws in. And for the TN, I mean, it's reduced literally perfect, Jeff, but the bite from the screws was awful. Like they were like no bite. So what I do? Well, I just made a little 2 centimeter incision, moved the tibant out of the way, and I didn't strip the capsule. I didn't touch the periosteum. I put a plate on and with 2 locking screws to just, because of her bone quality, right? But, when I was in the case with my residents, I'm like, they're like, well, you're making this incision. They're like, it's not really perk anymore or minimally invasive. I'm like, okay, so we made an incision. Did we strip the capsule? They're like, no. I'm like, did we touch the periosteum? They're like, no, we just put the plate on it. So I'm like, so did you devitalize any of the bone? They're like, no. And I'm like, so it's still minimally invasive in my mind, right? Like that's a little mini open incision. But to me, the philosophical nature of MIS, like it's not about the size of the incision, it's how we manage the soft tissues that underlie the skin, right? Because that's where the pain comes from. That's where the swelling comes from. And to be honest, my belief, and when Abic study, when he looked at the dye on the bunion, right? The periosteal sleeve is intact, and that's why it heals.
Yeah.
My belief in the fusions, you preserve all the periosteum, you don't do any stripping. So we make Aikens, distal metatarsal osteotomies, like all of these, we are preserving all of the biology. And I tell everybody, so if you break your arm or your leg and you cast it, what's the chance of that does not heal. It's essentially like zero. It's going to heal. The body's going to do its thing,
Hmm.
right? It's going to heal crooked, but it'll heal it.
Yeah.
With MIS, that's what we do. I like with a bunion, right? I think we just create a fracture, basically a closed fracture. I mean, we make a small incision, we cut it, and then we shift it, and then
Mhm.
we hold it there with an internal cast. The body heals it, right? That's why we can shift it 100%. And so I think minimally invasive surgery for me is preserving that soft tissue, not stripping it. That way we preserve the blood supply and we let the body do what it does best and heal.
I think the biggest takeaway from that case you were talking about, where you had to open it up a little bit, is not only the preservation of the soft tissues, but the ultimate takeaway, I think, is to not compromise patient outcomes just to maintain small incisions. At the end of the day, you have to do what's best for the patient, not
Correct.
try to, if you have to convert to full open
Doesn't matter.
to make it make a better outcome for the patient, that's ultimately what is important. But I like
Agree.
your philosophy from an MIS standpoint, because ultimately I think when you do compare the outcomes of patients that are open to MIS, whether it be in terms of lower pain and lower risk of infection and all these things, I mean, the evidence is fairly obvious when you think about it, and I think the results of the studies bore that out. But I think it's a shift, it's a mental hurdle for some people to be able to get over. If someone is like, I do this open, and you compared a subsect of patients who you did an open Lapidus versus an MIS Lapidus, and you looked at pain, time to recovery, all these things, I don't think you can ever say that the open procedure is better.
No, with the one caveat, and you had already alluded to this, it's done right.
Correct.
Right? Like, it's still like, right, you gotta get the reduction, you gotta reduce your IM, like,
True.
all of those things. As long as you do it right, I agree with you, right? And I think, like, the literature in a lot of arenas have shown this. And again, I will say that a lot of it is not per se. It's hard, and we'll have more literature, but you had already alluded to it. A lot of the times, it's the simple things that kind of really bother us the most. It's swelling,
Hmm.
pain, cosmesis, right? Those things are so much less in minimally invasive surgery because we don't do all that stripping, and that leads usually to faster recovery, less narcotic, and a really good patient experience, right? Like, and I'm sure you, just like me, you do an open bunion, and these patients would be like, "Oh, I'm never having the other side done." Now you do an MIS bunion, and at 2 weeks they're like, "When can you do my other side?" Because they still have a little swelling. They do. It's not like they don't swell, but they don't have the
Right.
pain, right?
Yeah.
And so the recovery is very easy, and you solve the bad problem for them without making them feel really bad in the process, right? Because that can be hard on patients. So I think, and again, every surgery, general surgery, OBGYN, cardiology, right? Or when you look at orthopedics, spine, total joints, everything has moved less invasive,
Yeah.
not because it's cool or slick. It's because if you can do the surgery right through minimal soft tissue dissection, patients tend to do better,
Yeah.
right? And that's across the board for surgery. And so you, all right, you hit the nail on the head. You do not compromise a patient outcome to say you did it minimally invasive, and I'll never do that. And I teach it, and that's why I put this case on there. If you got to convert to full blown open, you need to add added fixation. I mean, you'll see in the case, like, everything's done. You could walk away, but I'm like, I don't love those bites of those screws. Let's
Yeah.
back this up,
Right.
right? You want to do it, but as long as you can do it right and safely, then I do agree with you. I think most of the time the patients will do better. And then and I think that's just the nature of the less soft tissue disruption, you know?
Yeah. Are there any procedures in your mind that you have to open? Is there anything that you do that you say we can't do that MIS, or it's not better to do it MIS? Is there anything that jumps to your mind as MIS is not better?
Um Probably the wrong person to ask that question to, but can't do total ankle
Okay, sure.
MLS. There you
Yeah, not
go.
yet.
Not yet, correct. Yeah. So it really comes down to, the way I say is nothing. I think, again, I don't think MIS is per se a incision length, right? It's about how do we manage the soft tissues.
Yeah.
I will say in if you're doing like, so here's a good example, ankle fusion. I think a lot of ankle fusions are great, minimally invasive cases. I have done post-traumatic ones with bad varus or valgus deformity. But there, I think, are some, and I I will say one category I think, and I know this from it failing and not working and me having to convert to open is like club foot, like the deformity in that and the bone loss
Yeah.
and all the scar tissue from usually all their old surgeries.
Sure.
It's really hard to get a good reduction and get the joint opposed through a minimally invasive approach. And I've tried it twice and I failed both times and had to convert to open.
Hmm.
And I just won't do that anymore because the morphology of their
Yeah.
talus and all their scar tissue from all their surgery makes that really hard to do,
Yeah.
like in a percutaneous way.
Sure.
And so I think there's certain cases of certain procedures where you're like, you got to look at the patient, you got to look at the case, you got to look at the anatomy and say, is this going to give me trouble? Like I could try it. And I think there are times where I'll do that. I'll say, hey, let me. I mean, I had an ankle fusion on Monday that I thought I could do percutaneously, but she was really subluxed posteriorly and had a ton of wear.
Hmm.
Prepped the whole joint percutaneously, but I couldn't get it reduced like
Hmm.
well. And it was because I had the scope in there. I was looking. She had all of this like synovitis and scar tissue and things impinging on the joint and some very abnormal anatomy. And I couldn't get it reduced. And I had to basically open her up to mobilize the soft tissue to get it reduced. So again, sometimes I'll try things and it just won't work. And then I'll just convert it to open. And I think that's part of the learning. And I think it comes also down to what you're comfortable with. Like if you're not comfortable, like I'll tackle a lot percutaneously, and sometimes I fail and I just open. But I think there are a lot more things we could do less invasively than I think people think. I think there's a lot we can do. You know.
That's the classic surgeon answer. If something's not going well, you blame the anatomy.
Yep, that's right. That's right. It's the anatomy. It's always the anatomy, not
It's
me.
always the
My
anatomy.
tools and the anatomy.
All right. You want to jump into some cases here?
Whatever you want, dude. I'm here for you.
All right.
Right, so, and you just interrupt me, like, but I just put together some slides of like kind of how I do these things because I
Yeah.
think that's people are like, how do you do this, right?
Right.
And so I think one of the biggest things is people are like, who do you do these fusions on? Can you even prep the joint? What do you do with the cartilage? Like, how do you do your fixation? You know, uh, how do you remove all the cartilage? Who do I do it on? When do I not do it? What if I do it with the bone sucks? Do I do it with deformity or not? And I think a lot of these questions are what people ask, and my answer to all of them is like, I think a lot of these things are just like open. You just think most of these, if you can do it open, you can do it percutaneous. Not all of them, but a lot of them. So this is just a lady, obviously subtalar arthritis, right? Isolated, right? And so this is a great percutaneous case. I do it lateral beanbag. I use an anterior medial accessory portal, as you see there and
Mm-hmm.
there. And sometimes that's a posterior lateral portal, which I'll sometimes use if needed. So in her, you can see the two portals for the scope, which I marked out there. There's a
Yeah.
calc bone graft portal. I did a perineal tendinostomy.
Hmm.
So those are the prep sites for the burr. That's an accessory portal, and those were the portals for the perineal tendinostomy because she had some perineal issues too that I wanted to address.
So what did you do through the perineal tendon?
Just shaved them like a tenosynovectomy with a shaver.
Okay.
So I stick a camera in one side, shaver in the other, and then just debride them.
Okay.
Um, so I'll mark the joint here, make my portal. Then I always get in with the joint, make sure I create a little space pocket, right? Then put the burr in. This is from a long time ago. I now just use a 2x20. I use a 2x20 for every joint. That seems crazy, but The reason I do it is I get really good tactile feedback. It's an end cutting burr, it cuts on the sides,
Mhm.
and I can really I feel some of these bigger burrs, cartilage burrs, you can be really aggressive and you can end up taking way more bone. So the 2x20 lets me be way more accurate for my
Yeah,
joints.
I agree. Big one's
Um,
easier, but yeah, you definitely sometimes you check your fluoro and you're like, "Uh-oh, that
yep.
was more than I thought."
More than I thought. That's exactly right. So, this is just a video. I thought I was just going in, burring it. And then this is like I use a nanoscope in all these.
Mhm.
I got no affiliation with Arthrex, but I use it because it's disposable. And I always tell everybody I check my residents usually do my prep, my MIS prep,
Mhm.
but I always check it. I tell everyone to check it. I still check it every time, even if I do it because you'll be amazed at what you miss, right? And so some people are like, "Oh, that really costs a lot." I mean, you could use a 2.7 scope, but I feel it really again, we want to do this right. So the right thing to the patient, you can look on fluoro and it looks debrided, and then you
Yeah.
stick the scope in and you could miss half the joint. So I think to give the patients the best outcome, you should check it with a scope until you feel really comfortable that, Chris Miller likes to use a freer and his fluoro. Ettore Volcano uses the burr to feel. But until you've done enough of these where you have high union rates, you know what it feels like. And I still use a scope all the time because I feel I can dial it in really
I
well.
I think you
Um,
can miss cartilage even if you do it open. I mean, the subtalar joint is such an irregular saddle joint that it's easy to leave little pockets that you miss in there, even when you're doing it open. So I
I
think it,
agree.
I think it's a good tip to be able to look around and see and just verify. You have to
Yeah.
ask yourself, what would the patient want? Do you want me to leave a big pocket where it's never going to fuse because I missed the cartilage, or do you want me to verify that this is going to have the best outcome possible?
And that's exactly why I was like, what would the patient want? They want me to look at it, make sure it's done right. And
Yeah,
so I think all the cartilage, gone. And then like fix this with just two screws. This
yeah,
is for at 2 weeks, right? So at
wow.
2 weeks, my open subtalar would be way more swollen,
I was gonna
sinus
say,
tarsi approach. I
yeah,
mean, she even has wrinkles at 2 weeks, right?
yeah.
Completely healed for her perineals. And if you had to do her perineals and her subtalar, you would have a 7 centimeter incision there. And
Hmm.
so, and this is her at final follow up, you know, good union. And again, this is another one, calc fracture, arthritis,
Hmm.
you know, same thing, but you can see on the right, really fused well. So MIS doubles and triples, I think these are great cases. Everyone's like, oh, the navicular is so hard to prep, or TN joint, which I don't
Yeah.
disagree with. It is hard.
Right.
And they're like, well, what about all this deformity? You can do it. And again, if you know the anatomy, it's not that difficult because once you do all the joint prep, everything's mobile, right? So this is this I think I have in and out picture, but this is actually the case I did Monday. But this is again the anterior subtalar portal. That's just showing the nanoscope in there. I do
Hmm.
use fluid because I hook it up to flow because I think it clears things out and you can actually see. I don't try to flush out the cartilage.
Hmm.
Um, I will say in all of my fusions, every fusion I've done, I've had two non-unions and they're both two TN non-unions, and
Hmm.
one was I didn't use enough hardware. The other one was the navicular broke in the case, and I should have opened and put a plate on, but I didn't.
Hmm.
And it went on to those are my only two non-unions of all my MIS fusions, including every joint. So I never purposely try to flush out the cartilage
Why do you not try to flush out the cartilage?
because it is destroyed. The burr just destroys it. Like when you stick the scope in there, you don't see bits and pieces of cartilage floating around.
Hmm.
Like it's like just obliterated. I think the burr just chews it up into like minuscule pieces. And
Yeah.
so, and I think when I put the scope in, to be fair, I think it washes some of it out with the fluid running through it, but I
Okay.
don't actively try to get it out.
So
Um,
I do try to get mine out, but the only thought process is those are the cells, those chondrocytes, those cartilaginous cells that are preventing bone to bone apposition. So I mean, it's interesting to hear you say that. Obviously, you have good outcomes, so it probably doesn't matter that you're not working on getting those out. But just in my mind, I worry like, oh, I got to get those out and put in some bone grafts so that I don't have
Well,
anything.
I still bone graft it, and I'll show
Right.
you. We'll still bone graft it, but I think they're so beat up, and the bone is so healthy and bleeding and cancellous that when you
Mhm.
smash that bone together,
Yeah.
that those little bits and pieces, there's no cartilage left on either side of the joint. So
Sure.
now it's not gonna. I don't think those little floating around chondrocytes are going to do anything. And I think they're dead. Now that
Mhm.
they're disengaged from the joint, there's no more synovial fluid because you've opened the capsule and debrided everything. They're not going to stay alive. They're going to die. That's why I don't think they matter. Now, if you
Makes
don't
sense.
prep the joint and there's cartilage, that's a problem. But
Yeah.
if the entire joint is prepped and there's no cartilage left on the bone, you'll see in some of these videos, Jeff, the cartilage, like you can't even see pieces of cartilage left. I mean, like there was like in this video, this is like just right away sticking the scope in, and it's like it's all bone. Maybe there's a little fleck of cartilage floating around, maybe there, but maybe
Yeah.
not. That's some cancellous bone. I mean, you don't even see any. This is me sticking in the scope right away, right? It's
Yeah.
just annihilated.
Mhm.
Um, there's a little bit of cartilage left, just showing that you can see that. And then here is the rest of the joint prep. So the reason I show this is because this was just from the other day, but like then you can go back in and really dial in the prep and then go back and get those little areas. This is where I thought I had it fully prepped and it wasn't, right? So that's why I think it's good to look.
Are
Calf
you
bone graft. Go
Are
ahead.
you microfracturing after you prep
No.
because you're already down to bleeding subchondral bone?
Yep.
You don't feel like you need to
I mean,
perforate through anything
like, look
else?
at that. That is just healthy bleeding cancellous bone,
Yeah.
right? Subchondral plate's gone. Like, so I don't need I mean, it is mush.
Mhm.
It's so I don't think you need a microfracture at all because you just have healthy bleeding cancellous bone. That's what you want,
Sure.
right? Um, and so this is actually so I started doing this is why I put this in. So this is the lateral TN joint. So
Hmm.
I will mark the lateral TN joint on the lateral and then prep it because it's because of the medial tuberosity of the navicular, it's very hard to get in. But laterally, it's usually a flatter surface. So it's very easy to get in laterally and to get plantar and dorsal in the TN joint, as you see here. So you
Mhm.
can literally swipe dorsally to plantarly from the lateral incision, and you can get all the way medial. So I've done the dorsal portal, dorsal medial, dorsal lateral, all these different portals for the TN joint, but I think this is kind of my preferred. If I do a lateral portal that goes straight lateral to the TN joint, prep it, and then you get the majority of it. And that's my scope. Sorry, the picture's a little blurry, but left side of the screen is the CC joint. That scope is going all the way to the medial aspect of the navicular to show that you can get all the way across through that lateral portal. And here is what that joint looks like. So that's after my first pass with the burr, or my resident actually did this, but like that's showing just both sides of the TN joint. And one thing, because I will say, Jeff, I bone graft all of these because here's the difference. There is some bone loss when you do these MIS, and you can see that in this, right? You
Yeah.
do take often that's healthy bleeding cancellous bone. It looks beautiful, but there's a little bit of gaposis, right? So I think that when we do these, you have to bone graft
Yeah.
and you have to make sure you're getting a good reduction. Otherwise, you can't get a non-union because unlike when it's open and you can see the two ends smashed together. And here's actually the video. That's the medial joint capsule. I just went all the way medial to show that you can prep all the way medially. You can get all the way medially on that side, and then that's the medial TN joint. So you can get all the way there from the side. So I think what I was saying was you do have some gaps. So this is not like open where you know where you do it and you said you do it, you get it, and then you smash it together. You're like, yep, that bone is right, bone on bone. We can't see that.
Yeah.
So I think you have to do some bone grafting. This is just a picture of me using the scope and the burr to like dial in some prep, right? So when I
Mhm.
want to get an area of cartilage that I've missed, um, this is my resident there on the left doing. So this is a medial portal for the medial shoulder of the TN joint. So what I'll do is I'll open it up and then pin it and hold it open to prep any part of the medial side that I didn't get from the lateral side. So that's just a nice technique of holding the joint open. I'll give credit. My PGY4 resident now, John O'Keefe, who's going into foot and ankle, thought of that doing the pin. So I'll give him credit where credit's due. But that's how I'll kind of get into that medial shoulder. And
I
then,
I have 2 I have 2
yeah, go
questions
ahead.
real quick.
Sorry.
The
Yeah.
first is, are you effectively trying to flatten the TN joint at all? Because I find it hard because the burr is obviously straight to conform to the convexity and concavity of that joint. Are you trying to follow the morphology of the joint, or are you trying to make it kind of more of a flat resection in there and then just bone graft it back together?
So great question. So for the I'm gonna jump to the MTP joint because it's a similar joint as a
Yeah.
TN.
Yeah.
I used to try to keep the convexity, and it was a pain in the butt. And so I kind of do like flattish cuts. I know it shortens them a little bit, but I don't think it matters.
Okay.
I think that's really hard to do with the TN joint because you'd have to really flatten the talar head.
Yeah.
So I don't do that in the TN joint. I follow the concavity the best I can,
Okay.
right?
Sure.
Like, so it ends up like in that video, you're flat-ish, but you're not like really flat. I
Mhm.
do the best I can, right? But I try to and I'm always bone graft. Every one of these gets bone grafted, right? But
That's the second question I have. What bone graft?
so what I do is I do a mixture of allograft and autograft. So I always take calc bone graft. And then I do a slurry. And again, as you can probably tell, I don't care about money. I work at a hospital and I just do what I think is right for the patient. So I take Bio 4, which is from Stryker. I have nothing to do with that product. I just think it's a fourth generation biologic that's has a lot of osteogenic, genic and osteoinductive properties, and it handles very well, and it's easy to inject because I use, again, don't have anything to do with the dragon wing from Zimmer, but that's what I use to inject my graft. And I mix that with the calc bone graft. And we are going to publish some data here. We kind of looked at 300 of my fusions and the use of the autograft. We looked at autograft, allograft, and the combination of allo autograft. The allograft and the autograft mixed with allograft groups had the lowest risk of complications and wound infections, non-unions compared to the autograft group. And my belief is some people, and there are people who are doing this. Eddie Hop down in Mayo is looking at this. I'm trying to look at it. When this lady's 77, how good is her autograft? It's probably not
Mhm.
very good, right?
Mhm.
Right. So these newer generation allografts with all these various stem cells and BMPs and PDGFs, I think they're very different biologics, right? And I think they have a much higher rate of fusion than really bad autografts. So that's why I use it. And that's theoretical. And we have some preliminary data on 300 fusions, but there's some other people that Chris Gross at MUSC, similar data. And like I said, Eddie Hop down at Mayo's looking at this, but that's my belief. So that's my autograph. But any Vivigen is a Synthes. There's like Trinity. There's all these different companies that make these type of graphs that I think are very good. And I use them in every fusion, every case, every one. And I think that one thing I will say is that when you look at the bone and it's healthy bleeding cancellous bone, Jeff, when you put that together, I call it a smash plasty. It just kind of mushes. So it kind of molds together because it's all this cancellous bone, right? It's not
Yeah.
hard. You've taken the subcondylar plate down. So that's what I really aim for, getting to healthy bleeding cancellous bone. Because then I know when I reduce it, it's just kind of like mushes together, if that makes sense. It's
Yeah, and
very technical term.
there's going to be a number needed to treat. I don't know what it is, but if you utilize that product and you prevent X number of revisional cases, then the added cost of the original thing is going to supplant the number of prevented revisional non-unions in the future? I don't know
Oh,
what the
100.
number is, but there is a number that you say, well, this percentage of people would have gone to non-union. We're preventing that percentage of non-unions from having complications, more surgery, more hardware, whatever it may be.
So the funny thing that you that's why we did the study, because the hospital came basically after me and some other spine docs and was like, "Hey, you're using this. This is too expensive. You need to start using this." And I said, "Well, I use this because my non-union rate is probably less than 2 or 3%, which is far lower than the literature. But I think that has to do in part because of this graft. I think there's multifactorial, but that's why I use it, right?" And so then I was like, and I think that saves us cost on complications, hospital readmissions, and revision surgery. We did this study, and then I sent them the numbers. Right? I said, "Look at this revision rate. We basically don't we've had one revision in 3 years. Like, look at the cost of this compared to historical data." And then I didn't hear anything else about it. Right. So,
So it must have
and
worked.
you'll love this. I ended my email with, "What do you want me to treat your mother with?" I did. I said that for reals. And it
There's
wasn't, yeah. And so,
there's no
so
comeback for that. There's no like, okay, give my mom the good stuff, but the rest of these people, stop spending all our money.
yeah, but you bring up the salient point, like, and that's true. There's a number needed tree. So I don't think if you use stuff frivolously for no reason, then I tend to, there's always a method to my madness. And so
Sure.
I think that's why I use it. I think it's better for the patient, and I think we have data that shows that, and that's why I do it. So these are kind of some of the incisions, right? Some of the portals. That's a dorsolateral, dorsal medial portal for the TN joint. And then these are her. So a lot of those were this patient. So you can see she's flat foot, big TNM coverage, subtalar joint Kites angles increased Meary's angle. And so, this is her at final follow up, right? So really nice correction of her uncoverage, her Kites angle 0, Meary's angles restored. We got the talus back, totally fused, and those were all her incisions, right?
Those,
So
those, those look great. Those
bad
look great.
deformity. Yeah, I mean, bad deformity that we did all percutaneously, right? Um, this is another one. You can
Go
see,
back real quick. What
yeah,
are your thoughts on those beveled screws? I'm on the fence about them. I feel like I almost don't get as good of a bite. What are your thoughts on them?
compared to good
Just
of
like a fully threaded headless compression screw or something like that. Like the one
well,
that kind of tapers.
oh, like a variable pitch
Yeah.
compression screw.
Yeah.
Um, so the reason I use these, I don't think there's a problem with that, Jeff. I just use them because I like it's not the bevel, it's the fully threaded, right?
Yeah. Yeah.
I am, and you and I have talked about this before. I'm a big fan of fully threaded screws. Like in this case, I did use compression screws for the subtalar joint, which I
Mm,
normally do. But I'll
mhm,
be honest, you'll see. I'll show you the X-ray. I will show it to you from the case I did Monday. I used. Oh no, it's not. It was another case on Monday, but I think I used a fully threaded and a partially threaded in her subtalar joint because her bone sucked, right?
mhm.
And so I think the fully threaded have more fixation and more purchase. And if I have a good manually compressed, I don't use a lot of compression screws in my TN joint ever, because
Mhm.
I just like the 35 the 40 millimeters of threads. Now, if you have a variable pitch compression screw that's fully threaded, I think that's great.
Yeah,
These
that's what I
the
use.
beveled screws, I haven't had a problem with them.
Yeah.
I've used multiple different companies, Stryker, Anovis, Treese, and I haven't had a problem with any of them. The I think it's the bite. You're not getting compression; you're just getting fixation. And I think in bad bone, it's not going to be as good because there's
Yeah.
4 screws.
Yeah.
But I think if anyone has reasonable bone, then I personally have not had much of an issue with them. But I think putting again, you don't have to use these. I just like them. You can use compression screws. You can use variable pitch screws. You can use whatever you want. As long as you get the thing reduced and held with good fixation, I don't think it matters.
Yeah.
Um, so again, another case you can see a lot of uncoverage, right? The talus is
Oof.
really plantar flex on that navicular.
That's a
And
mess.
so again, I did a triple on her. So CC joint, TN joint, and MTP fusion. And I'll explain the MTP fusion in a second. So the subtalar, you can see the triple really restored her height nicely, got her uncoverage fixed. Again, I used beveled screws for both the TN and the CC joint, healed well. Subtalar joint healed fine. So here was what we talked about earlier. So I do all my MIS fusion. I did an MIS fusion, right? So what I did was prep the joint percutaneously. Then I put in my first screw, and her bone did not feel great. I didn't
Mhm.
love it, right?
Mhm.
So rather than putting in another cross screw, I just made a little dorsal window, moved the EHL, and then dropped the staple on top,
Yeah. Well, that was a
right?
wicked hallux varus. I'm sure that there's been some bony erosion, and the subchondral bone there is just gonna not be good. That thing
Yes.
hasn't been functional for a very long time, I'm sure.
No, I agree with you. So that's again to your point, like small little incision, still minimally invasive, but do the right thing for the patient, right?
Yeah.
These are her incisions, right? This
Wow.
is like her, like I you can't even see them, and then this is her standing. And the funny thing is, the left side. So we did the right, yeah. So the right side is the side I did percutaneously. Look at the left side. The left side, she had an open triple.
Mm.
You can see her scars, right?
Yeah.
And the left side is an open triple done by a very good surgeon. And she had a very good outcome. So just like we talked about, she said the right side, she goes night and day difference in her recovery. She's
Yeah.
like the right side, she's like, her left foot feels great. She has zero complaints about her triple on her left, but she's like, oh my gosh, this right side was 1,000 times easier and better,
Yeah.
right? Which was your point earlier, right?
Exactly. Yeah. And that's the
But
best case study is the same patient feeling both surgeries.
yeah, that's right. That's exactly right. So this is the one, I'll show this one, and then we can end with whatever you want to end on. But this is the one from I think Monday. I don't have foot X-rays, but you can see on her talus is totally falling off the calc. You can
Yeah.
actually see her subtalar instability on the AP view and her
Yeah.
subfibular impingement, her collapse. I get a weight bearing CT scan because I have one. So I was just showing for your audience the uncoverage, like severe uncoverage. And so again, open the subtalar joint. And so here on the right side, Jeff, that's my smash plasty. That's just me squeezing it together. And you
Yeah.
can see how much the joint closes down. Then
Mhm.
I bone graft. So this is what I'm saying. I'm just showing how you can bone graft. And this is, like I said, I use this thing called I don't have any financial interest in this. It's called the Dragon Wing. I just like it because it loads fast. I think Brad uses it.
Mhm.
But have you ever used it?
No.
No, but yeah, so whatever. You can use a trocar. You can open. I used to use pickups, but they're a pain in the butt. This just allows me to jam it in there and get it where I want. So you get nice filling.
Yeah.
Then this is prepping the TN joint. So now look, this is me after all my prep. So subtalar joint looks good. And look at I'm reducing the TN. That is bone on bone. That
Mhm.
is completely reduced. So this is what I was talking about. The contour is not so bad either, right? It's not amazing, but and I showed the video of earlier what the prep looked like. It's all cancellous bone.
Yeah. That looks
So
good.
so here is the X-ray. So subtalar fusion. So A to P screw, and then I put that fully threaded screw in because that first screw was like, ugh, that did not have good bite,
Hmm.
right?
Yeah.
And then I put in those two other screws in the TN joint, and you see I have my third wire for my third screw. And
Yeah.
I'm like, you know what? These two screws, that's a 6.5 screw and a 4.0 screw. And they both felt the same. I'm like, this lady's bone and the reduction looks good. Everything's been done percutaneously. So this
Yeah.
is where I opened. Like we restored her anatomy, everything looks good, but her bone was soft. So then I
Yeah.
just made that little incision and put that 2-hole plate on with
Mhm.
locking screws. Made me very happy. I think
Mhm.
reduction looks good. And these are her incisions. So on the right, you can see those are subtalar, TN, her screw, her calc bone graft, one of her screws. And then I made this little dorsal incision. There's the tib ant. and I just moved the tibia out end of the way. I did not strip her periosteum, her capsule, and I just put the plate on dorsally. So, absolutely no stripping. And, that's her foot plate, right? So her simulated weight bearing. She's got a nice arch now,
Yeah.
good tripod. And so, again, to our point, I think it's important to show, look, you don't sacrifice the patient. I mean, I did the whole case percutaneously. Then I'm like, oh, I got to make a little incision. That's fine. Do the right thing. I still think we did a great job correcting the deformity minimally invasively. And then we have to make a small little incision where we don't strip and we just put a plate on to back it up. So that's all. I
Yeah.
think that's just we don't have to be all or nothing in minimally invasive surgery. We just have to do the right thing.
I think that's a very reasonable outlook.
Yeah.
You want to do one more?
Sure. MIS ankle fusions. This is a post-traumatic case, obviously. Distal tibia and then ended up having ankle arthritis. So I use standard anterior portals like you would for a scope.
Yeah.
If you can't get in the back or there's some deformity, you can always do a fibular osteotomy with the burr and just go laterally if you want to maintain some curvature or if you need to like correct some deformity. So one thing, I know this is crazy, but I'm a little crazy. I actually started distracting the ankle fusions, and I have a picture because it pulls the talus anterior and plantar flexes it. So it makes my ability to get the posterior talus and the posterior tibia way easier because the
Yeah.
ankle's distracted. The talus is now plantar flexed, and the back of the talus is facing you. So it's really easy to get the full prep. And then you just take it out of distraction and you get the front of the talus. I don't know. It just made it way easier for me to do. So I kind of set it
Yeah.
up almost like a scope
Yeah.
and then like that. And then it honestly just takes probably like 10, 15 minutes to prep the joint. And then this is like you can see anterior, there's a little bit of subchondral bone I have to get, but look at the whole prep. I mean, you can see the whole tibia, you can see the whole talus, you go all the way to the back, all healthy bleeding cancellous bone.
Hmm.
And again, this is why I use a scope because I can really dial in what I want to correct, but how much you can see and how well you can actually prep the joint on the first pass, which usually only takes a couple minutes. I mean, right? I mean, won't you agree? Only
Yeah.
like the prep most joints, the first pass at least doesn't take very long. I mean, probably
Yeah.
no longer than your incision to get down to the joint,
Right. Yeah.
right?
Exactly.
Um,
And one thing we did not talk about is how much time and energy you save on the back end with closure.
Closing. Yeah.
Oh, that's like my least favorite case. The case is done, and then it takes however long to close
30
whatever you're
minutes to
working on.
close the wound, right?
Yeah,
And
brutal.
splint. It's a pain in the butt.
Yeah.
Um, so then these are her incisions, right? So I did do a fibular osteotomy in this lady, but I did anterior medial portals. Those, or maybe that's actually her screw. I didn't do a fibular osteotomy. And those are my kind of my standard construct. I do two, and here, look how many compression screws I used.
Hmm.
0.
Yeah.
Right?
Yeah.
And these are her final follow-ups. I see all these at a year, but
Do you?
I do 2 medial, 1 lateral. My buddy actually Isaiah Sandlin, he does a screw from the fibula into the talus just to kind of help the screws that are holding. And I was like, oh, that's a cool idea. Why not do it? It's just from a stability standpoint, which I kind of like. And, you
Yeah.
know, um, again, this lady didn't have great bone. I wanted to choose elderly, post traumatic, not great bone. So I just used fully threaded screws all around and she healed fine. She did great.
Are you
So,
prepping the lateral gutter for
yeah.
that screw?
No, I don't prep the lateral gutter for that screw specifically. I do prep the gutters in general just to create more bone slurry and surface to fuse, right?
Okay.
But
Yeah.
I'm not I do prep the lateral gutter and the medial gutter just again to get rid of the cartilage
Sure.
and create more bone slurry and hematoma,
Yeah.
but I don't do it for that screw, but then the screw goes in. So
Yeah. Sure.
I got a lot more, but I know but I think these are just some examples of I think how we take various concepts. We want to make sure we're doing the right thing. We do the right thing for the patient, and I think we can get really good outcomes. I mean, in this lady, I mean, You can already see her skin. She's skinny, doesn't have great soft tissue envelopes, already has some scars from her old surgery. And this is her, after her stitches are out at 2 weeks, and I mean she's healed,
Yeah.
right?
Yeah.
Big difference.
That's fantastic. So
Yeah.
those are
So
great
luck
cases. I think you gave us a ton of great tips and pearls there. So thank you for sharing those cases.
yeah, dude. All right. I hope that was not too much talking, but probably was, but whatever.
No,
You can edit it, baby.
that's what yeah, exactly. That's what people want to hear. That's the gold. That's the stuff that they want to that's the info that they want. So, I really appreciate you hopping on with me tonight.
No, of course, man. Thank you. Yeah. Any questions? I'm happy to answer them. Any other, you want to do more cases anytime, you just let me know. But I really appreciate you having me on and inviting me here. It was a real honor. So thank you very much, man. Appreciate it. Always,
Absolutely.
always good to chat with you.
Absolutely. Where can people find you? You hang out anywhere online with
Mainly LinkedIn. Just
Yeah,
find me on LinkedIn. I don't do really IG or Facebook or TikTok or Twitter or X, I guess now.
too
But
many
I'm
things.
on LinkedIn, and I gave you my email, and people can always email me if they have questions, or find me on LinkedIn and DM me if they have questions. But always happy to help people get into MIS or questions with MIS. I think it's the wave of the future, and I want to help everybody who wants to get into it and better patient care that way. So
Absolutely. Great philosophy. You know what's crazy is we went an entire hour plus and did not talk about Azatic.
we did talk about Azadic.
Well, but we didn't really like hammer down on the Zadig.
No,
We
but we
mentioned it in
talked about it.
passing.
We talked about it.
You had to throw it in there.
I always have to throw it
You
in.
gotta
I
throw it
always have
in.
to throw it in. I did.
All right. Thank you so
My
much
favorite.
for
It's my favorite.
yeah.
All
So
right.
check out Tyler on LinkedIn, and all his publications are available out there. So check it out. Thank you so much for hopping on.
Thanks, brother. Bye.
All right. Thank you everyone for joining us on this episode of Paw Patrol with your host, Dr. Jeff Dikis. We'll see you guys next time.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.